Excuse me. Good morning or afternoon, everyone. This is Brandon Garrett, the National Minority Quality Forum. You know, it's Friday, so we try to at noon, so we at least noon on the East Coast. Sorry, Kelly, but Friday on the East Coast, and we try to I say edutain because we're going to make sure this is good and entertaining and make sure we're educated about a health issue that's we've been working on here at NMQF. It is the 26th of September and it's the last Friday of the month. So you know that our team from SHC will be leading today's webinar. It will be called From Awareness to Action, Improving Alzheimer's Outcomes Through Equity and Early Diagnosis. Chine Ukachukwu will be leading the webinar. And fun fact, Chinny's done this webinar at least 10 times, and it's the first time I've said her full name. But before I get into this, I have some housekeeping items. One, if you have any questions, please put it in the Q&A box. And if two, just to keep the conversation rolling, put it in the chat. And without further ado, I'm going to turn it over to Chinny.
Thank you, Brendan. And yes, you did a better job than any other time before now. So well done too.
Thank you, thank you.
Good afternoon, everyone. Thank you
Yep.
so much for joining us today. We do not take you for granted that you choose to spend some of your Friday with us. We say welcome, welcome, welcome. We have an interesting conversation so around an Alzheimer's toolkit that we created. And so I'll be your moderator today to guide that conversation. And my name is Chini Okachukwu. Just a little bit of a background. Alzheimer's disease is the most common cause of dementia in the US. It affects over 7 million Americans today with a disproportionate impact on Black and Hispanic communities. Early detection is critical, not only for managing care, but also for giving patients and their families the opportunity to plan, to access resources, and to participate in clinical trials. Before we dive into this conversation, I want to give a big shout out to our friends at Biogen who have supported us tremendously in this effort, both financially and otherwise. We've had brainstorming calls, we've had sessions where they helped us tweak our materials and made sure that they continue to be both sound scientifically and relevant and culturally relevant. So shout out to the Biogen team. We started our relationship with the Biogen team really in 2020 when the NMQF, the National Minority Quality Forum, and Biogen came together to develop what is called the Clinical Trials Learning Community. It is a model that identifies and mitigates disparities in clinical research and has served as a space where local researchers, clinical researchers, physicians, patients, and community leaders work toward a common goal, which is reducing disparities in care and outcomes for underrepresented patient populations who are living with serious chronic conditions by ensuring awareness of these conditions and access to clinical trials that are closer to home for the patients. The initiative actually started with lupus, and under the leadership of both the National Minority Quality Forum and Biogen, we have measured already tremendous progress in reducing disparities and continue to expand access to education and clinical trials for the communities that we've been serving. Building on this model, Biogen has supported NMQF again to extend this effort in the CTLC, as we fondly call it, in the CTLC space to focus on Alzheimer's disease and related dementia. Leslie, I will ask you to please share the advisory board report that we developed recently with the Biogen team and the community in Alzheimer's in the chat, if you will. The partnership is part of what makes today's conversation really possible, and we are grateful for Biogen's ongoing commitment. We'll also, like I said earlier, we will be exploring the toolkit that we created that will help provide us that vital conversations, help us reduce stigma in the communities, and support patients and their families better. Before we dive into this discussion, I'd like to welcome formally my panelists who will be having this conversation with me, and I will give them each a moment to introduce themselves. We'll start with you, Dr. Cohen.
Hi, I'm Jason Cohen. I'm a neurologist at Montefiore Medical Center in the Bronx, and I specialize in Alzheimer's and other dementias.
Thank you, Dr. Cohen. Ms. Kelly?
Hi, everyone. I'm Kelly G. Loeb. I'm a social worker and the Community Engagement Coordinator at the University of Kansas Alzheimer's Disease Research Center, which is one of about 36 such centers in the United States. And we provide information, resources, support, and research opportunities toward prevention, treatment, and cure of Alzheimer's and other dementias.
Amazing. Thank you so much, Kelly. And of course, Miss Terry.
Hi, everybody. I'm Terry Branch. I am a health champion and a wellness warrior as well with University of Maryland Health and Equity under Dr. Thomas. I am also a realtor and a upcoming community healthcare worker. I just finished my course and my practicum, so I'm excited at the end. So, and a community advocate as well.
Awesome. Thank you so much, Miss Kelly.
Welcome.
I just want to share briefly my screen just to give you all a visual insight to what the toolkit looks like before we go into the conversation. So we start off by talking about what Alzheimer's really is. So Alzheimer's 101 is what we're calling it, what the symptoms are, then quick facts, and all of these have links that you can further explore to give you more in-depth information. We go into quick facts about Alzheimer's, then the importance of early detection, like I said, the resources for early detection, why is clinical research important for Alzheimer's? Then we go into disparities. We talked about how it affects disproportionately Black and Brown communities, and then we put numbers to it so you can see for yourself. And then we talk about the diversity in clinical research. Who's already represented, who needs to be more represented, clinical trial resources. Then we go into what our team has done, which we call the Alliance for Representative Clinical Trials, further trying to build out diversity in clinical research. And then we try to hone in on culturally appropriate care for the communities we serve. We address the issues of social determinants of health. We talk about implicit bias. Why do some people why is this conversation easier in some cases and in some instances and maybe not so much in other instances? We talk about tips for good patient and provider communication. We give you conversation starters, both for patients and caregivers, reflection questions, and then we go into drive. Drive is how we really measure the quality improvement part of this, hopefully this project, if you will. And then part of Drive, the first step in Drive is identifying who the champions of the project will be, completing a brief assessment survey that you can access through the QR code, learning more about your community, what's relevant for them, then picking an activity, picking a project, picking a task, picking something you want to improve, and then putting your plan into action, communicating with the team, celebrating and continuing. And then, of course, our links or email if you have any questions for us. So we'll be dropping this in the chat as well so that you all have access to it. And now we'll go into our conversation. So, Dr. Cohen, I'm going to start with you. You contributed immensely in the shaping and in the curation of this toolkit. What gaps would you say as a provider that this supports, and how does it help patient care? And what we're trying to address, and how does this really help address those things?
So we wanted to create something that was relatively short and balanced to help support our primary care colleagues to talk about cognitive impairment and evaluate for cognitive impairment and dementia. And so, everything from, well, why is asking about cognitive symptoms important? And with a reminder, right, ask specifically about it at the annual wellness visit. And there's research, for example, to support that a direct question about that is better than just observation. But why is asking about it important? What symptoms should we be asking about? How do we start the conversation? So having those ideas in one place, quick tips, resources, but then taking a step back and putting it into context of, well, really, why is this important? What are the numbers? And then, but wait, what factors might impact our patients, or what patient factors might impact how well I'm doing or how well the primary care doc is doing? And why might I not get the best outcomes for my patients? And we were focusing here on more on race and ethnicity, but giving that little nudge of, oh, well, there might be things that we can do to make sure that our care is accessible, equitable, and nudging people towards better outcomes and helping people recognize this and some of the barriers. And there are toolkits that are out there. There are resources that are out there for all of the things that I mentioned. A lot of them go into great depth. A lot of them are not necessarily intended for a primary care audience, because a primary care doctor trying to address someone's blood pressure, heart failure, their leg swelling, this thing on their arm, and also their memory in a 15-minute visit, which is, right, I don't know how they do it, but we wanted to make it, again, balanced, relatively short, practical, and accessible. And then for the people that say, but wait, I have an opportunity here, I have something that we can do about it. Well, that's where the drive piece comes in at the end is, oh, well, maybe I have these extra tools at my disposal if I want to fix something about the system, because improving care for one patient is good, but figuring out a way, not reinventing the world, but figuring out a way to change a practice, to do some sort of quality improvement or other, to make it just that much easier to take care of my next patient really carries forward. So again, a balanced resource, not intending to be comprehensive for everything, but making this practical, I guess is the longer answer.
Thank you so much, Dr. Cohen. Appreciate you. Ms. Terry, you looked at the toolkit, and I'm sure you saw the conversation starters for providers. From your experience, how important is this? How important is it that clinicians initiate these conversations with their patients, and their families early on?
I think it's extremely important for clinicians to start these conversations early. What I do appreciate about these conversations, the toolkit, is that it includes the family. Y'all know I'm a bag of water, so excuse if the tears come. Because most of the time seniors often normalize memory loss. You hear them say, "Oh, I'm just getting older," And so it kind of helps the family to input, and identify concerns that might not otherwise be shared. Like, I noticed she's forgetting to turn the stove off. I noticed she's forgetting to do certain things. Or, and so from my own experience with my mom, I've seen how, we can provide doctors with context that they normally wouldn't get from, like, my mom. She's old school, so she's raised to take care of herself and handle it at home. You got a headache or too long, don't go to the doctor. Take some medicine at home. But with this, going to a doctor's appointment with her and them asking these questions trigger me to be able to give my input. So early conversations to me build trust. It reduces fear because I'm a scaredy cat and something's going wrong. It keeps me from panicking because I can say, this is what's happening, doctor, and see what they say, when they're asking these questions. And it allows us as families to plan together with the doctor. The doctor's not doing it all, but we're not doing it all. So if we feel like a big family, the doctor's part of that family. So that keeps us, I think I really like the early conversations initiated by the clinician, by the clinicians. That's why.
Thank you.
Mm-hmm.
So it keeps you aware of what's going on, but it also
Yes.
helps you, figure out with the patient, kind of like, do we need a second opinion? Do
Yes.
we need to find out if there's more to this, or is it just part of aging? I like
Mm-hmm.
that. Thank you so
Mm-hmm.
much.
You're welcome.
Kelly, the toolkit underscores the importance of addressing disparities and practicing cultural competence. How would you say providers can use this to better serve Black and Brown communities, who we're especially targeting older adults?
Sure. Wow, Jenny, that's a fantastic question that I have some answers to and some questions about my own self. And I'll tell you my answer through the lens of working in Kansas, which is a state where maybe you might think, are there a lot of Black or Hispanic people? And the answer is yes, particularly in the urban area of Kansas City where I live in St. Louis. And then also across what we call the Great Plains. We've got farmers from all kinds of cultural backgrounds, and Kansas is most likely a more diverse state than you recognize. And the gift in that for me is that I have gotten to work with a lot of populations, and in particular, these populations that we especially emphasize as not having received as much information and support as they deserve through a disease like Alzheimer's. And so providers can use a toolkit like this to supplement what we hope is very broad and meaningful education in their training, in their medical school, in their residency, in their continuing education. But also, let's keep it real. The best way to meet the needs of a community is to hear from the community itself. And I think the toolkit does a really nice job of aligning what we know in terms of professional study and formal education alongside the very real lived experiences of Black and Brown people with this disease. And I love that the toolkit encourages providers to say to patients, what is meaningful to you? What's most important to you, instead of being up here on my high horse with all these letters behind my name. And I got letters behind my name too, but all these letters behind my name means I read some books and I took some tests and I, put on this white coat. Whereas the person with the lived experience of this disease can say, oh, this thing you have in your toolkit, that was helpful for me. This other thing, maybe not, but let me tell you what does work. And so I think that if providers can practice what we call cultural humility and say, I am here to support you. I'm here to offer you the information that I know, as well as to receive the wisdom of your lived experience, then things like your toolkit will do a great job of helping all of us managing caring for someone with dementia.
Absolutely. Thank you, Kelly. Hey, we invite you not to take our word for it. I dropped the toolkit already in the chat, so please go through it and see for yourself what we're talking about, especially when we talk about things like the conversation starters. We give actual examples that you can use, and of course, like Kelly said, there are tips that you can build off on, right? It doesn't mean that we have captured everything that there is to it, but we invite you to take a look and use them as starters for your own conversation with your patients, with your providers. All right, back to you, Dr. Cohen. So the toolkit, another thing that the toolkit emphasizes is the importance of early detection. What early signs should providers be alert to? And how can the toolkit guide them in reducing the stigma when these concerns are raised?
So the early signs, so Alzheimer's is the most common type of dementia. Dementia is this broad umbrella. Underneath that umbrella, there are many different types or causes of memory problems that are bad enough to get in the way of your day-to-day life. So dementia, the umbrella, Alzheimer's is the most common. And so recognizing the early signs of Alzheimer's is key. So the person who's repeating oneself in a conversation, forgetting recent events, maybe repeating yourself in a conversation, getting lost in familiar places, changes in mood, and other symptoms. But then kind of the second most important thing is once you have that main pattern, well, what doesn't fit the pattern? And so by helping primary care docs understand, well, what's the main pattern that we're looking for, then you could say, well, this doesn't fit. There's something weird here. There's something different. And thinking as broadly as we can about, access to care and availability. We know that there are not enough neurologists around. In some places we have more than others. New York, we have a lot. Kansas, not as many. And in many rural areas in the country, we know that there is a very large unmet need. And so making sure that we're helping people spot the patterns of when there's something weird, when is there going to be perhaps more benefit to that referral can be an important piece. But recognizing the pattern, I think, also helps with the stigma is oh, I recognize this, I've seen this before, and that comfort and that familiarity already helps reduce some of the stigma of this is not something weird and different. Oh, of course. Well, what kind of memory problems? Do you have A or B? What kind of pattern? And that often helps put patients, families, other caregivers at ease as this is not something weird. oh, well, there's 7.5 other million people like my mom who have memory problems. There are about 20 million other caregivers who are in my shoes. Oh, someone has been there and done that before me. All of that reduces the stigma, improves communication, and ultimately makes it a little bit easier for everyone to get the best care possible.
Thank you so much. Appreciate that. And Miss Terry, I see you wiping your eyes. I know that this is very personal to you. And again, I want to shout you out for participating here, to tell your story, to help inspire hopefully someone or a few people. But I also wanted to ask you, you know, what resources in the toolkit stand out as most helpful for families like yours who are navigating this disease or the diagnosis of this disease?
The most helpful part of the toolkit for me is the patient provider communication. Um, it's important for providers to use, simple language because sometimes we're not doctors. So it can be scary to hear all the acronyms and the fancy words and things like that. Having visual aids sometimes help. And I'm saying this because these usually help my mom a lot and us to understand what's going on. But also like written materials, things like that, because medical jargon can be kind of confusing, and breaking down the information in smaller pieces. Because sometimes you can leave a doctor's office and there's so much information that you feel overwhelmed. I'm sorry, y'all, I'm having a heart. I'm sorry.
No, take your time. Take your time.
So when the patients trust the doctor, like as my mom does, it creates an environment where we feel we can be more open and we feel supported. So the patient communication is physician communication is provider communication is really important to me. Like I said, when we can take something home that okay after the doctor has told us this and we can kind of read a little bit more about it or see something that breaks it down. Um and being open pretty much if we have a question after that we can ask that question, a follow-up question or whatever. But yeah, but that's the most important part to me, the patient um and provider communication.
Yeah. Thank you.
You're welcome.
Thank you.
You're welcome.
Um, as she was speaking, I was thinking about the fact that there are diseases, there are lots of diseases, right? But it's hard. There are not a lot of diseases that let you refer to a loved one as the patient, right? And when you see the person physically in front of you, but not able to do simple things like even remember who you are, that's really challenging. And again, Miss Terry, we appreciate you for being here to tell this story, to
Yeah,
participate in this conversation.
it
It
was important.
cannot be the easiest thing to do.
Yeah,
Hearing these things said and knowing that your mom is one of those people we're talking about.
yeah,
And
yeah.
so I don't take it for granted. I'm sure nobody here does. So thank you again.
You're welcome.
Um, Kelly, what role does culturally relevant messaging play in building trust and encouraging families to pursue screening and clinical trial participation, as you have seen in your role?
Sure. On the one hand, we can talk about Alzheimer's disease being an equal opportunity disease. We know that people of all races, genders, socioeconomic status, geographical areas, we know that it's not a respecter of persons. All kinds of people get Alzheimer's disease. We also know that because of some biology, because of way systems are structured in the world, because of access or lack thereof to resources, that some folks get Alzheimer's disease more often. And the really maddening part of that is that they don't even necessarily know that that's what's happening. because they don't have as much information. And it's easy, as well as misguided, to say, well, this community doesn't have as much information and they're not accessing that information. It's easiest for us to sort of say that, but we should shift that blame, and maybe I should say responsibility, back on those of us who are informed and are aware. It is our responsibility to be culturally competent and even culturally humble and say, we have these deep wells of knowledge. We've been working on this disease I've been in the Alzheimer's community since 2001, so almost 25 years. And there was a world of information that was happening before that. So it is incumbent upon us to go out to these communities and say, here is a thing that is happening. It is not normal aging. There is something we can do about it. To echo Ms. Terry's point, early detection and early diagnosis are so critical. We are not yet at the point where we can say we have a cure for this disease. So if you do this, you will not then have Alzheimer's disease. But we are absolutely at the point where we can say, if you are showing these signs and these symptoms, here's what we can do about it. We can get medication on board early that will hopefully slow some of that symptoms and buy us some time to have conversations, to plan, to think about quality of life, to contribute to the store of knowledge that we have, not only for ourselves, and we are allowed to be selfish about this. We are allowed to say, I need help. I want somebody to look at my brain and my body and figure out what's going on and see what they can do for me. But we also have a responsibility to say, for the children of today, folks, little kids that are in elementary school or high school or even college, we want them not to have to deal with this. We literally want Alzheimer's disease to be a memory. And we have to make sure that we are doing that in ways that are effective for the communities we serve. And when I say we, I mean me too, because I'm a member of a community that has historically not had access, has not been aware of what to do and where to go. I considered it a great irony. I don't know if I'm using that term correctly, but a great irony when, after I had worked for the Alzheimer's Association for 5 or 6 years, not one, but both of my grandmothers were diagnosed with Alzheimer's disease. And I thought, well, I'll be darned. So this wasn't a get out of jail free card. This wasn't, I should have had a pass, right? I've been working on Alzheimer's disease for all these years. How dare whoever decides these things, how dare that person or that system say to my grandmothers, who had been otherwise healthy, I mean, nothing wrong with them other than just being Black women, how dare they get Alzheimer's disease? So I consider that my personal and my professional responsibility to equip not only my immediate family, but my surrounding community, and anybody who I can get to listen as a community engagement and coordinator about what it is we know, what it is we have yet to know, so that we can indeed resolve this problem before, I'll say it, I'm 49, before I'm in the group that's more likely to get Alzheimer's disease. I don't want this either. And I have some real good reasons to know why I don't want it. I don't want anybody to have it. And I think that that's why we are all called here today to talk with you, Chenny, about what we can do about that.
Absolutely. But can you speak specifically about the role they're using culturally appropriate materials?
Yes.
Yes.
I can tell you that a big part of my role at the Alzheimer's Disease Research Center, where I'm employed, is to create those kinds of materials, to recruit and enroll and retain people in research participation in particular. And when we come up with what we call collateral material, like a flyer or a brochure or a toolkit, like your beautiful toolkit that you've put together, we have to be very intentional and very thoughtful about even what pictures we use on that material. Because if somebody is going to see that brochure or that flyer, even in their doctor's office or at the library or their community center or their place of worship, they need to see something that says, you are welcome here, you belong here, and even more than that, you are safe here. We are here to provide you some support and some scaffolding. Yes, that means we want to look at your brain activity and we want to know your health history, but we are doing that to take care of you, we're not weaponizing information. We are not saying there's something wrong with you. We are not saying you are different and we want to study you because we think that's weird. We are saying we embrace you and we want to make sure that the strategies we're working on for prevention and treatment and cure are as appropriate for you as they are for anybody else. Listen, I'm a big fan of research. I have to say that because it's my literal job. Today was payday, so I get paid to say that research is important. But research is so important. Without research, gosh, I guess I maybe shouldn't get too much into the current events today, but if not for research, we wouldn't have great things like vaccines and medications and potential cures for Alzheimer's disease. And I'm so grateful that we have them, but we need to make sure that we have them for our most vulnerable people. And as a social worker, I learned when we help the people who need the most help, everybody benefits. And I think that's where that cultural competence comes in. And that's where that focus on, are we meeting the needs of this community in the best way that we can? If we do that, then we can say, yes, we are addressing this for everyone.
Absolutely. Thank you so much. And just hearing you say that, I want to shout out Dr. Cohen, who has also done some amazing, amazing work with one of our churches in New York, a predominantly Hispanic population, where he went and provided some education in Spanish, and answered some questions that folks had. Dr. Cohen, I'll just give you a minute to tell us a little
Yeah.
bit about how that went.
And well, that, and also just to add on to what Ms. Loeb said, and part of it is, well, when you open opportunities for, oh, this group, that group, well, you open opportunities for everyone. And right, you're in Kansas, I'm in the Bronx, slightly different. But the things that allow increased access and opportunity to folks in certain disadvantaged communities, well, it turns out that rural communities also have massive barriers to care and some of the same programs. So every time we think about, well, we can help this group, no, we're helping everyone. And really, every time we do this, we're really taking care of everyone. But on the other side, even for the person who wants to be selfish and think, well, that's not me. Well, if you only study a disease in old white veteran males, right, who live in a particular county in Minnesota, I'm like, well, you don't know that disease, right? You can't only study a disease and only think about symptoms in a massively tiny little sliver of the population and think you know anything. Right? You don't. And so making sure that we are having an open mind about not only the people that we are working with, but also, well, wait, what symptoms matter to you? And oh, I didn't even think to ask about those symptoms, those facets of the disease, or this way in which it manifests. Well, now I'm going to learn more about the disease itself. And then again, I can then turn that around and help everyone else. So um, taking a very narrow view doesn't really help anyone, even in the people who are in that narrow view. It helps everyone to think more broadly. So, for example, at the it was Our Lady of Sorrow, I guess specifically Our Lady of Sorrow's Church in Elmhurst. So it's one of the most diverse communities in the planet in terms of different countries that people are from per square mile, or languages that people speak as their primary language per square mile. And so a lot of it was, no, this is not, you're not crazy because you have dementia. No, this is not normal. Right? If you have a change from how you were before, right? Everyone's different. Some people have access to education, some people don't. Some people are literate, some people are not. Some people don't speak English as well, and maybe they got a test from their doctor in English, and really it should have been in your primary language. But a change from how you were before is not normal. And starting the conversation with, hey, is there something here that maybe we should help with? And then the other piece is, no, you're not alone. Look around. There are a lot of other people here who are also going, huh. And I think those were the two most common themes that I saw. But we see that in all of the communities that we work with from rural New York State. We service the upper Hudson Valley that might have a lot of farming communities down to inner city Bronx and everyone in between. And it's a common theme is, oh, other people like me are also doing this.
Thank you so much. And Dr. Cohen is humble enough not to tell us that it was so successful that the church actually requested he come back. And if you're in the New York area, on the 3rd of October at 6 p.m., you can catch him there, especially if you speak Spanish. I don't know if there'll be a translator, but he'll be there again on the 3rd of October at 6 p.m. Thank you so much again, Dr. Cohen. So let's talk a little bit about engaging providers with this toolkit, Dr. Cohen, how would you say that it helps to, it would, that it will help conversations from providers to patients and making these conversations less stigmatizing, especially, and empowering for patients and their families?
So, as Ms. Branch mentioned, the conversation starters are very helpful. I ask people how their memory is dozens of times a day, but for the person who's not asking those questions, they could be a little bit weird. For the surgeon who, is just did gallbladder surgery, right? How are you pooping, sir? Right? Did you fart today? Right? That
Mhm.
that is their normal. They do that 1,000 times a day, and so those are
Mhm.
normal questions. They don't think twice. But if you don't do it all of the time, it could be a little bit weird. And we want to try to take away that little extra hurdle and say, no, no, these are different ways that you could start. These are ways that you can get the conversation going. These are the questions you could think about asking just to make that a little bit easier. And once you start asking, once you start getting that dialogue going, okay, now we can make more progress and progress in an easier and faster way. Again, we got to make sure that we're taking care of our primary care docs so they can do this in an efficient and easier way.
Thank you. Ms. Terry, when you look at the toolkit, how would you say that providers can create a safe space for caregivers' voices, especially in the diagnostic process?
Say it one more time because my phone rang in the salon rang and it interrupted what I couldn't hear
All
you.
right, no worries. I said, when you look at the toolkit, how would you say that providers can create a space for caregivers in the diagnostic process? How can they provide the caregivers more when they diagnose in the patient's journey?
Um, I would think just allowing us to be in that space and have a voice in that space because um with my mom, it was this one, not saying all physicians do this at all. It was one physician, it seemed like it was a problem for us to ask questions.
Mm.
Um, I it takes my mom a little more time to get certain things out, which a lot of times they do. And she was kind of rushes. I kind of jumped in and kind of explained that my mom, I said you can do it, you can do it, mom. And I'm trying to talk her up to the point where she answers the question. But it seemed like she didn't want my input when I told her it takes a little longer sometimes for her to get out what she has to say. And I didn't feel like at that moment, I didn't feel like that was a safe space during her diagnosis because they were talking about it. She didn't understand certain things, and I was trying to help her, and it seemed like it was like almost like she was telling me, "Be quiet. I'm the only talking to her," and I didn't feel like as a caregiver because me and my brothers and sister helps with my mom, not just me. My brother, she actually stays with my brother. We just kind of rotate different things because she used to stay on her own, and it just felt like it wasn't a safe space for us. So that's why I really do like the toolkit because of it discussing these things and um the suggestions of how we can make that better. Um
Okay,
yeah.
thank you. So just making sure we have a complete picture in case there's someone who ever finds themselves in that situation. How did you all navigate that? What would you recommend if you had to think about it now? What would you suggest to someone
To fix that type of
to
problem.
fix that? Yep.
Mm. Well, we had a conversation with the doctor. And I don't know why, if she was just having a bad day that day, because she was kind of standoffish a little bit. But after having a conversation and letting her know, look, this is new to us. We're hurting. We're nervous. We don't understand. She doesn't understand. And there are certain things that she can't verbalize and say. She wants to say it probably, but she can't get it out. So we all kind of in this together, and we're looking at you to guide us and to be there for us so it feels safe. So we had a conversation, and our next, me and my brothers and sisters, we had talked about it, and then she hadn't kind of fixed that. We were just going to move her from that position. And this is not her regular physician. This is not her primary physician. is another doctor that she was going to for a specialist, pretty much for that. And you know, she was just from walking in, she was like that. But we had a conversation with her and had our next, if she hadn't corrected that, we were just gonna seek other medical, you know, another doctor, pretty much.
Absolutely. So
Yeah,
it's safe to say that if you're not comfortable with the provider, it's okay to find a
that-
second opinion or a
that's
third.
right. Or and go somewhere where people make you feel like they care and it's not a check. Like we all get paid. I sell houses. I want to get paid for selling the house, right? But if a client is, I had a client that had a leg removed, right? And he could bring $2,000 to the table. So I reduced my commission to help him with that, right? So it wasn't just about the money, it was about the love and that we're all human, that we need to support one another, you know? And so I did that for him. And so what I was expecting from her was to have a little compassion, to have a heart, straight to the point, just to have a heart and understand that my mom couldn't verbalize as quickly as she wanted her to, and that it was coming, or to let us help her with that, you know. So if she hadn't fixed it, we were just going to move her after that conversation. I believe in talking to people because she could have just been having a bad day,
Yeah.
you know, something, and she's seeing it all the time. So maybe, you know, it was getting to her by the time she got to my mom, but I want her to understand how she was hurting us by doing that and making the situation more challenging for us. So
Absolutely.
she fixed it. She fixed it.
I'm glad she did. I'm
Yeah.
glad she did. So sometimes we may need to have those difficult conversations on behalf of our loved ones to make sure that the space is
Mhm.
safer and
Hmm.
more empathetic for them. Thank you.
You're
All
welcome.
right, back to you, Kelly. From your community work, what strategies would you say have been most effective in reducing stigma and empowering patients to seek help?
Oh, Chinny, this question, I love the answer that I'm going to give you to this question because it beautifully talks about cultural competency and meeting people where they are. And it's something that first started in a rural Kansas community, and then we duplicated in urban Kansas City. And when I tell you the same thing worked for these two disparate groups of people,
Mhm.
it's miraculous. So it started back in 2001 or so in Southeast Kansas, in a little town I'll shout out, Parsons, Kansas. And there were a group of farmers who would get up early in the morning and do their farm work, whatever that entailed. And then they'd meet at the diner in town. And if you go to a small town diner, you know that you sit at a stool, right? And you're not facing anybody. You're facing maybe the kitchen and the waitress who calls you honey and brings you coffee. And you're sitting in a row of 3 or 4 other fellas. And you're talking about, forgive me, the real farmers of the world, but you're talking about the crops coming in or not, and the rain, and the tractors and all the farmer talk. And eventually the talk turns to, well, how's your wife doing? Because these are all old guys, right? Old white guys, even. And they're talking about how their wife burned the toast or she didn't remember to do something. And they don't call it Alzheimer's because that's just not, they're not there yet. And they line up and they start saying another familiar phrase, me too, me too, me too.
Mhm.
And it turns out they meet for coffee every morning at 7 o'clock or whatever their time is. And they don't look at each other. They look straight ahead, but they talk about how their wife is having a hard time and they're not sure what to do. And eventually that turns into something called the Breakfast Club. Don't call it a support group. You cannot call it a support group. You can't even really formalize it. You just meet at the same time in the same place and you drink your coffee and you say, how's your wife? And it goes from my wife burnt the toast to maybe we need to go see the doctor. Maybe we have to drive up to Kansas City to see the doctor because we live in, you all know what a food desert is. We live in a neurology desert, as Dr. Cohen mentioned. We have more old people in Kansas than we have neurologists or social workers even to support them. So over time, this became a regular gathering and they ate their coffee, drank their coffee and ate their bacon and eggs or whatever it is you get at the diner. And it worked. And we never called it a support group, but these old guys felt supported. They felt like they had someone to talk to who understood. And eventually we snuck another old guy in who was an actual social worker and he guided their conversation. So this worked really well in Southeast Kansas. Meanwhile, 3 hours north in Kansas City, we're finding that old Black men and women are having these same dilemmas about caring for their loved ones with Alzheimer's disease. And they're not going to go over to the Kansas side of the state line, which is not even very far. Parts of Kansas are closer to Missouri than other parts of Missouri, but they're not going to Kansas, to a city called Prairie Village, Kansas, which doesn't really sound like a place for urban people to go. They're not going to go sit in a circle and tell strangers about their feelings, but they will come and get a free breakfast at a church in their community. They'll come and eat bacon and eggs, just like the old guys on the farm, and they'll drink coffee. And they'll sit at a table and they'll say, gosh, this morning was really hard. I almost didn't make it here today. And they'll have me and my colleague looking just like them, and both of us having had experience of being caregivers, saying, you are not alone. And we never called that a support group either. We just found a church that would host us. And we did sit in a circle because it was easier to serve the breakfast that way. And we did look at each other. And on the second Saturday of every month, starting July 13th, 2002, and continuing to today, and I'm telling you, that's what, 23 years, except now we meet on Zoom. We have said, we are here. You are not alone. Just come have breakfast. We don't even have to say the word Alzheimer's disease, but come have breakfast. And we'll make it a breakfast like you might eat. We'll have some grits. And we'll have, everybody likes coffee. And we'll have this food, and we will nourish your body and we will nourish your mind. And you will know that you can go back home to your husband, your wife, your mother, your grandmother, your sister, your cousin, whatever, and feel like you are not alone. And I just love that so much, that these two vastly different audiences responded to, I see you. You are not alone. I am going to help you. I see you. I see me. I look like you. I relate to you. And this is not meant to leave anybody out. Hear me on that. This is not meant to say we don't want to help people that don't look like us. This is meant to draw the circle in and to say, we've got something specifically for you that can nurture you. And I think that's wonderful. And if I were the entrepreneurial type, I would have copyrighted it or trademarked it or whatever, but that's not the way I operate. I just think everybody should do something like that in the way that works for them in their community.
Wow. Powerful. I
Mhm.
had goosebumps all over as you told the story. That was really beautiful. Thank you so much for sharing that. And I hope you all cut that message. Thank you. So the time is far spent. I can't believe it. We're almost done with the time. But Dr. Cohen, when you look ahead, what advances in Alzheimer's research or treatment really gives you hope?
So there are a couple of things. So again, very, very grateful to the research. We have a long way to go, which is also why engaging people and making sure we get everyone into trials if they're interested, if that's for them, is so important, because the number of trials out there is exploding and we need tens of thousands. I don't remember what the latest number is, but just for the later stage clinical trials, I think the number is somewhere around 50,000 people to be in the studies, because it's really easy to have a good idea. It's not so easy. It's easy to have a good idea, but to read before I tell that person, hi, I think this will work for you, I have to have some proof. I have to have data. I have to be able to say, I may not work for everyone. There's no magic silver bullet, but I have to be able to say, yes, we have checked this medicine, this diagnostic test, this whatever, in someone who is like you. And the majority of people who are like you, this works. And in order to do that, you need people. You need a lot of people and a lot of time. And so getting people and getting everyone in is critically important. But in terms of the advances, so a lot of folks are looking at these new Alzheimer treatments. There are two approved just in the last couple of years. And I think that's a very important step, not quite as good as they need to be yet. They're getting there. And even within those medicines, we're making improvements. And we hadn't had a new medication that was actually approved for 2 decades almost. But for me, actually, the biggest advancement is in the diagnostics, the blood tests, the new brain scans, because if you go back 20 years and you say, oh, well, I had an Alzheimer's disease research study, it turns out about 20% of the people in that study didn't have Alzheimer's. Oops. And a big proportion of those people had Alzheimer's, and they also had another disease. They had a different problem at the same time that was also messing with their brain. And if 20% of the people in your study don't actually have the disease you want, and another 20%, making up that number, have two diseases and not one, and they're both, well, you're never going to find the treatment you want. You're never going to find the thing that you need to take care of that person. And so the thing that I'm most optimistic about is our advances in getting the diagnosis right, and hopefully getting the diagnosis right faster, easier, cheaper, and that works for everyone, because again, most people don't have access to a neurologist. There's, depending on the numbers you believe, maybe 15,000 neurologists in the whole country right now. It's probably closer to 10,000 who are practicing. There's 1 million people with Parkinson's. There's 800,000 strokes a year. There's 7.5 million people with Alzheimer's, probably 2 million people with Lewy body. And like, those numbers don't work. We need to make these diagnoses faster, easier, cheaper, more reliable. And once we get that, then all of a sudden, all of our other research gets easier, gets faster, gets cheaper. And in an age where research is under, I guess, under attack might be a understated way to put it, where research opportunities, dollars, spaces are harder and harder to come by, anything that makes research easier, that makes research faster and cheaper, will ultimately help us get those treatments and ultimately those cures faster and better. So really it's on the diagnostics, which is not the sexy whatever, but to me, that is where the future is getting you the answer. It's also important for patients, right? Having a
Yep.
name, right? You have your problems because of this, and I can't do something about it today, but tomorrow we're going to work with you. We're going to get you there. But this is what you have, and why you have it is really powerful. So it's on the patient side, it's on the research side, on the clinical side. To me, it's the diagnostics.
I agree. Thank you. Thank you. I like that. All right, Miss Terry, as we begin to wrap up, what would if you had one message to share with providers about supporting families, what would that be?
Just, I think I'll probably sound redundant, just that we're all in this together. It's challenging for all parties. I know that they're busy and they always see so much of this back to back to back to back to back. But when we caring for our loved ones, with something, it's all new to us, and patience, is just a must. Because we dealing with something that's new to us. I just feel like um coming together and supporting one another for supporting us as we're trying to take care of our families would make it easier. And the patient side of it is the biggest thing for me, because there are going to be some questions that sound crazy. There are going to be um some emotions and things like that, but patience and compassion from the providers, to me, will make the journey less overwhelming for everybody.
Absolutely.
Yeah.
Thank you, Miss Terry. And Kelly, as you wrap up, how would you say that national resources like this toolkit would best complement local outreach efforts in diverse communities?
It's so helpful to have a national toolkit that is broad enough to address everything we know already about Alzheimer's and other dementias, but that locally people can take to their healthcare providers, to their community centers, their worship facilities, and say, how can we take this information and make it relevant to where we are, wherever that might be. Having a national voice makes us realize the universality of this disease. And our strongest hope, of course, is that we can prevent, treat, and cure it. Our other strongest hope is that none of us will ever get it. But our reality is, as we heard Dr. Cohen say, 7.5 million people have this disease in the United States. There are 50,000 people, or excuse me, 10,000 people turning 65 every day. And that's not a magic number. That doesn't mean on your 65th birthday you get Alzheimer's disease. But it does mean you need to be more keenly aware of possibilities and of taking care of your brain. So I love the toolkit. Even if you don't have a diagnosis or even a concern about diagnosis in your family, it's never too early to take a look at those pages and see what we know and see how what we know might apply to your life. Here's a shameless plug for my and other research centers. So we know things like a good diet that has a lot of avocados, for example, is probably good for your brain health. Your brain is doing well now. Take that research that we're sharing with you so generously, right? We're really good about that, and use it for yourself so we never have to see you at the clinic in the future. We are looking for people who are cognitively healthy to participate in research as much as we are people who have a diagnosis, because we need to know, how did you get to be 93 years old and you're still driving a car and doing your job and dancing and living your best life? So things like that national toolkit are useful not only for someone in the process of the diagnosis, but also in terms of prevention and just general awareness. Because when our communities know what's happening, we can be more supportive about that. So I think the toolkit is a great thing, not only for people who know they're dealing with a diagnosis, but also for any of us who want to be supportive of those who we love.
Absolutely. Thank you. And as we all know, time always gets away from you when you're having the best conversations. Two things. Kelly, there's a question in the Q&A. Well, yes, it is a question. It says, are you available to chat with me?
Yes.
This is from someone, Alena. I hope I'm saying your name correctly. Are you available to chat with me to maybe give some feedback with what I do as I work with families? And I will put Kelly's contact information in the chat since she says yes. Then the other question is for you, Dr. Cohen. It says, with shortage of neurologists, who will care for millions of patients once they are diagnosed?
So I'll give the shortest answer to that I can is we are trying to fix that at every level. So both encouraging medical student, both getting more people who might be interested in medicine but otherwise discouraged, otherwise have barriers into medicine, getting more people in medical school interested in neurology, within neurology, getting more people interested in dementia. Even if you are not going to specialize in dementia, making sure that every neurologist has had more education about dementia, reaching every psychiatrist and making sure our psychiatry colleagues, our primary care colleagues, our geriatrics colleagues are all as familiar as possible. So some of that is really, force extenders or force multipliers, and some of that is through some of the grants we have. So there's the Geriatrics Workforce Enhancement Program through HRSA, so we appreciate their support. New York State has programs, but a lot of it's education. It is teaching as many people as we can on the health professional side, and it's also through education in the community and our community champions, because the more education we have, the easier it is to take care of more people with, unfortunately, insufficient resources. And empowering our primary care doctors to do the bulk of this is the reality. 32,000 people in the Bronx right now today with Alzheimer's disease, never mind the other dementias, and I am the only neurologist between the top of Manhattan up to Albany who does dementia full time at about 2.5 million catchment area. And so it's force multipliers. It's education, 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 support, and education. So yes.
Thank you so much. Thank you so much to all of you for sharing your valuable insights today, and to everyone who joined us. We've heard today about how the Alzheimer's Toolkit can support providers in early detection, empower families with clear and supportive conversations, and help address disparities through culturally relevant outreach. Together, these perspectives highlight the importance of combining clinical expertise, lived experience, and community engagement to improve Alzheimer's care. We encourage you to review the toolkit, which I put a couple of times in the chat. Share with your colleagues, use it as a resource in your community. I've also included another set of amazing resources that will help you and your communities as you navigate this disease. And on behalf of our NMQ family, the panelists, and of course our friends at Biogen, we want to say thank you again, and we look forward to continuing this important work with you. Have a wonderful weekend, everyone.
Thank you.
Yes, Lois, I'm sharing the toolkit again. Everyone else, you may drop. I want to make sure that Lois gets this before we close the recording. All right. And it is there now. And I have your email, so I'll also take it and forward it to you. Okay, have a wonderful weekend. Thank you so much, everyone.